Okay. So my name is Irina Galuga. I am the Director of Operations for the Preparedness and Treatment Equity Coalition, or PTEC. And today I have with us one of our grant awardees, Julie Sonier. Is that right?
Yes.
Okay, great. And I'm just going to have maybe give a little bit introduction about yourself and where you work so people can have an idea of what it is that you do.
Great. My name is Julie Sonier, and I'm the President and CEO at Minnesota Community Measurement. We are a nonprofit, and we're really a collaborative organization that brings together health plans and healthcare providers and employers and consumers and state government in Minnesota, all to collaborate on creating a common source of trusted data that everyone can then use to drive improvement in health outcomes throughout our state. So I sort of first came to this work as I'm really trained as an economist, and my graduate degree is in public policy. And really, I was drawn to this field because of the ability to use facts and data to solve important problems. And so Minnesota Community Measurement, an organization that really is all about data and driving improvement, is really a great place for me.
Okay, so what are you working on right now? I know that you obviously have a lot of probably simultaneous projects going, but what are some of the most important things that you're working on right now?
Right, so we have a combination of what I would describe as the core of our work, which is ongoing work that's been happening for quite a long time, as well as some of what are the emerging efforts. So in the core of the work, we do a great deal of work around measuring and reporting on healthcare quality. And we do that by collecting clinical data directly from providers. We do it also by aggregating data from health plans. And then we've got another piece of this work that relates to healthcare cost and utilization. Within the quality pieces, we also have some really long-standing efforts to get everyone in Minnesota on the same page about what it means to collect data from patients about race and ethnicity in ways that are, number one, consistent and meaningful and conform to best practices. And because of that, we've been able to build up sort of this really solid foundation for the project that we're going to talk more about, but like this incredibly rich data source about variation in healthcare quality and outcomes by race, ethnicity, language, and country of origin. So that's kind of what I would describe as the core of our ongoing work. We have a few kind of emerging efforts that are also really exciting. One of them is really kind of wonky and data focused. It relates to how do you collect data for quality measurement in ways that are, take advantage of modern technology and really reduce the burden of this for providers, because especially when you're talking about outcome measures, right? And those rely on clinical data, you really need to figure out how do you do this in a way that makes the most sense and does it efficiently and that people find timely and actionable. So that's one of our kind of emerging effort focus areas. Another one is that we are exploring with stakeholders the potential for kind of adding to our data collection, or just like I described, getting providers on the same page about collecting race and ethnicity data, whether there is potential to also do that for health-related social risks. So things like food security, housing security, transportation, that we know are big contributors to differences in health. There's not really currently data that exists on that, and we don't know very much about who's collecting that data from patients. Are they using similar practices or not? So we're really in the very early stages of starting that conversation in our region about what does the landscape look like now, and what would a collaboration to do this in common ways potentially look like?
Yeah, those are two very interesting and like you mentioned, it's sort of the amorphous things. Like a lot of people are thinking about collecting that data, but it's now becoming a question of what even the data is, right? You know,
Yeah.
if you say race and ethnicity, well, people define that in different ways. You know, I've come across different studies and spoken to, different groups that kind of have slightly different ways of binning those sorts of things.
Mhm.
And same thing with social needs. You know, I think that's definitely a conversation that's becoming more and more significant. Same kind of thing. How do you define homelessness? How do you define food insecurity? All of those sorts of things. And when you're dealing with stakeholders who are approaching it from different directions, I think that's definitely a really important conversation to be having. So now, when you're thinking about the investigation that you proposed for this grant, it very much ties into what one of the areas that we're really focused on, which is looking at particular illnesses that are more common or perhaps have a more significant effect on health outcomes for particular racial and ethnic groups. So could you perhaps tell us a little bit more about what you proposed to do and sort of how you came to that investigation?
Sure. So we have long had the desire to dig deeper into some of the data that we have about disparities, to be able to make sort of more actionable information out of it. And
Mhm.
it's just that, simply always been a question of resources and time available to do this. But part of the core data collection that we've done for many years is a pair of measures that represent outcomes for vascular disease and diabetes care. And when I say outcomes, I really mean, the things that the clinical evidence shows that if these things are well controlled, then leads to a lower probability of a complication of chronic disease
Mhm.
for people who have this disease. And so it's things like blood pressure in control, and for diabetes, the A1C level, and tobacco status, and for heart disease, whether people are taking an aspirin every day. So we've had these measures for a long time. And as I mentioned, we have a really rich set of data on
Mhm.
it's patient level data, and it includes information on race, ethnicity, preferred language, and country of origin. So what we're envisioning really, so we have this great jumping off point and the desire to do this work. And so what we really lacked was like the ability to like get some resources to do it. And so that's what we're really excited by. And one of the other things that we have is a longstanding partnership with the Minnesota Department of Human Services, which is the Medicaid agency in our state. And so for many years, we've done reports for them that look at these variations in quality outcomes by insurance status, because they're responsible for purchasing healthcare
Right.
for now over 1 million Minnesotans who are insured by their program. And so they have a strong interest in figuring out, how do we as a purchaser get the best value, like for taxpayers' money, of course, but also the best outcomes for the people that these programs serve. And so together we've been trying to think about ways that we could, get deeper into this analysis to really understand some of the reasons for disparities. And of course, you can always dig deeper, right? So we were just talking about food and housing, and I was like, well, we don't have that data yet, but some of what we do have is this variation on where people live. And what we hope to do is really goes so much differently from this path where you start to think about people as homogeneous groups, and you should say, well, within this group, so within the Black population in Minnesota, for example, we have a large Somali immigrant population, which is different from the African American population in some significant ways, including sometimes which parts of the state they live in, age distribution, and so what's exciting about this is the ability to potentially do this analysis in ways that help us understand at a more granular level what some of the barriers are.
Mhm.
So it might not be the same for everyone. So for some groups of folks, it might be, gosh, we really need to work on tobacco cessation status. But for others, it might be really like getting into healthcare to, have your blood pressure taken and and manage medications to make sure that blood pressure is under control. So that's kind of what we're hoping the results of the project are, is kind of this better look at where the opportunities are. And they're not the same, right? Because groups are not homogeneous,
Right.
but to say for these groups of people in this situation, this is where the opportunities are. And they might be different for a different group of people. So
Yeah.
that's kind of what we're hoping the sort of the end result of this analysis is.
I think that's something in a lot of this work people aren't looking at as much as the fact that groups are not homogeneous. And like you pointed out, for example, Minnesota, which is a more diverse state than a lot of people might think it is, that you have this large Somali population, which has a different history. They have different, like you say, age distribution, different approaches to health and well-being. And one of the things that when I was reading a proposal that kind of stood out to me was looking not only at race and ethnicity, but the language and country of origin. And those are just really critical parts, and perhaps one of the most interesting things about what you're doing is, kind of disaggregating these groups and having this granular information to say, if we have, we look at the Black population, but we have people who are Somali speakers with maybe limited English proficiency, how do you approach their needs? I think that's a really interesting, I would love to see the outcomes of that, because, I do believe that they will be very different, but that's a hypothesis, right? So that was something I thought was really great, was just really being a lot more direct about the fact that we have so many more differences than kind of what we think about right now in a lot of health equity work. We're just kind of binning people by race, but it's more than that, right? There's so many more factors than that. So, how did you come across the grant call for proposals?
So I'm a member of Academy Health and sort of read their newsletters and happen to notice it through that. I don't know how else you all were promoting it, but and we already had this twinkle in our eye, like, boy, what could we do if we could figure out if we could get some resources to support this work. So when we saw it, it seemed like such a great fit, including the fact that the program is focused on two of the areas of interest for the program were diabetes and vascular care, where we happen to have some really good
perfect,
data,
right?
Desire to do more with it.
That's absolutely perfect. And I think the other thing too is that you're really focused on implementation. Like, how do we take the work that we're going to do and directly impact populations that within Minnesota who are really in need of more care, better outcomes. How do we do that? And I think that, again, is something that was really important to us when we were looking at proposals, is something that's not just descriptive. So you're not just going to be looking at the numbers and saying, this is how many people we have in this, racial, ethnic group, so on and so forth, but we have this data, how do we use it? Now, can you tell me a little bit about the racial, ethnic, language distribution in Minnesota? Because like I mentioned before, a lot of people might not think Minnesota is a state that perhaps could, generate data that could model for the rest of the country, model best practices for the rest of the country. So, can you describe a little bit about what the state looks like?
Yeah, so like off the top of my head, I can't tell you exactly, like, this is the percent of the population that's white versus Black versus, but, you're right. So a lot of people say, well, Minnesota historically has been thought of as a really, a very white state. But I would say over the course of the past 30 years or more, some of the most rapid population growth in our state has been among populations of color. So I already mentioned the large Somali immigrant population. Another group that really is a large group immigrants is the Hmong population. Many of whom, have spent a lot of years living in refugee camps in Thailand and
Mhm.
before settling in the US. And so those are some two pretty large communities, but also there's a fairly large Hispanic population as well. And if you think about a state that is geographically as diverse as Minnesota, right? So like we have Minneapolis, St. Paul, where a little over half the state's population lives, but then we've got these, agricultural centers and some so when you've got like these big like pork processing areas so there's a lot of immigrants working in those
Right.
because as well, and those, so the rural, very different from, the rural and urban populations as well.
Mhm.
So, certainly it's been an area where there's been a lot of change in the state. And,
Right.
I don't want to sort of let it go by that, of course, Minnesota was sort of the epicenter of some of the upheaval that was sparked last year, which, related to, the death of George Floyd and, some of the other incidents that got some wide national attention. But and those are horribly tragic and shine a light on some of the realities of what in this case it was disparities in sort of the way that the justice system treats people. But we have known for a long time that we have large disparities in health outcomes in Minnesota, in part because of the data that we collect and
Right.
publish. But what is good of the outcome of all of the events of last year, in COVID, of course, disparate impacts on different populations is
Mhm.
another kind of driving factor here. What's good about all that, if you could say that there's a silver lining, is there's this such a strong sense of urgency for change and
Yes. Yes.
responsibility to do something about it that I have never seen in my career here. And so, we're trying to do our part to sort of add to that momentum
Mhm.
and make sure that we hold ourselves accountable for actually getting better outcomes.
Yeah, and this, like you said, there's a silver lining to this, and that a lot of these underlying issues that some of us have been working on for a long time became you sort of emerged to the public consciousness. And so there's a lot more opportunities for funding, for, even people just recognizing that this work is important, right?
Mhm.
So do you see so you said you're a nonprofit and you have like this, great mix of stakeholders who are invested in your work. One of the groups that you have is payers, right? You mentioned the Department of Health Services, who is responsible for Medicare in your state, right? Um, have you seen with the payers that are stakeholders a change? Perhaps it's fueled by the events of the last year, or maybe initiatives they had been working on internally. Have you seen that they have more of an interest in looking at these racial and ethnic health disparities?
Yes, absolutely. It's always been important, but I would, sort of like rose to the absolute top of everyone's list last
Mhm.
year. And so they see it, it's no longer kind of a nice to have and a nice thing to work on. It is an absolutely essential thing to work on. And I would say that's from the perspective of, so it's not just health plans that are serving the Medicaid population. In Minnesota, it tends to be the same group of health plans that are serving like privately insured. And so it's not like we have plans that are very many plans that are just Medicaid.
Yeah.
So it really is kind of like all of them at the table saying, this is really important. We need you to do this. We all need to be part of this.
Mhm. Mhm. So the outcomes that you are hoping for are, I think, um, things that are very relevant for practitioners, for payers, for consumers, for all, healthcare stakeholders across the country. So how do you plan on sort of giving, you know, what am I trying to say? Disseminating the results that you have. I mean, for example, even just figuring out a way to have a universal reporting system for race and ethnicity. I mean, something like that would be absolutely amazing. So how do you plan on kind of getting the word out about your results, other than what you'll be doing with us?
Mhm. So one of the things that we'll be doing along the way is working with an advisory group. So like we've got the analysis piece, right? But then there's the so what, like what do you do with it? What are the action steps? And of course, the project is 6 months long. You don't have a lot of time to like plan an intervention and implement it and evaluate it. So this is really about the analysis and then like bringing it in, then making a plan together for, what is everybody's role in the solution? And everyone does have a role in the solution, right? So even if you think about employers that are, have employees who they're offering health insurance to, there are things probably that employers can do that are, going to contribute to getting better outcomes for people who have heart disease and diabetes. So one example would be, well, implementing things that you can do that reduce cost barriers for people to, go to the doctor to manage these chronic conditions. And there's likewise, there are going to be things that health plans can do, and there's going to be things that healthcare providers can do, and there's going to be things that community-based organizations can do. So part of our vision is to kind of develop this roadmap to say, okay, here's what we learned, and here's what all of these different people who have a part in the solution, here are the things that each one of them can do to address it. So, so that's part of the roadmap, and I think it is going to be relevant beyond just Minnesota. And so that's part of the plan for like what the end result of the project is going to be and how we can disseminate the lessons learned from it.
Okay. So want to again be mindful of your time, and you're probably a very busy person. Sounds like it. So do you have any like last thoughts that you'd like to share about the work that you're planning to do with the group?
So, I think what I want to emphasize is how, first of all, how excited we are to be doing the work and really kind of like getting down to creating, I would say, a lot of, we do a lot of work where we're just, generating numbers and putting them out there in the public sphere, and to have the opportunity to say, well, let's hold on a second and see, what insights we can generate from this, along from like, just here's a bunch of information, and hoping that people do things with it. So making that connection between, here's the information, here's some of the underlying reasons that contribute to the disparities that we see. So not just describing the fact that there are disparities,
Right.
And here are some, here are some of the opportunities. And again, thinking about this not as, homogeneous groups of people, but things that would be actually tailored to different groups that really could, sort of resonate with the people that you're trying to reach in different ways and, lead to results. So that's particularly exciting to us.
And I think that's exactly what we're looking for with these projects. And I think, everyone who's funded has a different approach, but ultimately getting different heads together to solve this really complex problem of health inequity and, disparities between, and, if you start disaggregating within groups. So again, I really want to thank you for your time today and, being able to share with us who you are and what you're planning to do. Yeah, I'm really glad that you applied. I really loved your project, and I'm really looking forward to seeing how things progress over time.
Great, we are too. So thank you.
All right. Bye.
Thank you. Bye.
Bye.